Venous thromboembolism is a very common disease in our country with approximately 1.2 million events each year. Of these, caffeine thrombosis is extremely common and accounts for approximately half of all of these venous thromboembolic events. There may be as many as 300,000 cases each year. My name is Robert McBain. I am a professor of medicine and I work in the Uganda Vascular Center as a vascular provider within the Department of Cardiology. This article will be appearing in the May 2021 edition of the Mayo Clinic Proceedings. The title of this manuscript is Caffeine Thrombosis Outcomes Comparing Anticoagulation and Serial Ultrasound Imaging Management Strategies. Caffeine thrombosis can be described as involving the deep veins of the calf, and these can be either axial veins, which are the posterior tibial or perineal veins, or the muscular veins, which are the soleal veins and the gastrocnemius veins. Caffeine thrombosis is unique in that it does not include proximal vein thrombosis as an entity. The problem with caffeine thrombosis is that there are few randomized clinical trials to inform clinical practice, and there is a clear bias of providers and patients regarding how they would prefer to be managed in this context. For example, we recently tried to perform a randomized clinical trial at our institution, and unfortunately, we were not able to recruit patients because of this clear bias despite the absence of sound data. The guidelines, for example, would recommend a preference of serial ultrasound imaging weekly for 2 weeks over anticoagulation therapy unless patients have severe symptoms or they're at risk of propagation. However, the guidelines are problematic because these are based on expert opinion only. And furthermore, there are few validated risk prediction tools to identify those individuals who are at greatest risk for thrombus propagation or embolization. Furthermore, between the imaging intervals of 1 week, propagation and embolization can occur, and this would be in the context of the patient being at home without adequate supervision or monitoring. The study objective of our study was to compare outcomes of patients with caffeine thrombosis treated with anticoagulation compared to those who were managed by a strategy of serial ultrasound imaging surveillance. To accomplish this objective, we reviewed the vascular ultrasound database from January 2016 to August 2018 to identify all cases of isolated caffeine thrombosis. We excluded all patients if there was any evidence of proximal deep vein thrombosis or thrombus at other locations such as pulmonary embolism. These patients were then followed forward in time for thrombus propagation, embolization, venous thrombosis recurrence, major bleeding, or death outcomes. Over this 2-year time interval, we were able to identify 483 patients with isolated caffeine thrombosis, and of these, less than 20% were managed by serial ultrasound surveillance, despite our guideline recommendations. The vast majority, more than 80%, were managed with anticoagulation. When reviewing the indications or the reasons why providers chose surveillance ultrasound imaging, 60% were following the guidelines, 20% of patients had active bleeding and therefore would not be a good anticoagulant candidate, and 20% had had recent surgery. Of the anticoagulation group, which again was the majority, these patients were treated for 3 months. We then looked at venous thrombosis recurrence composite, which was a composite of venous thrombosis propagation, embolization, or new venous thrombotic events, and found that these were twice as high in the surveillance group at 14% relative to 7% in those receiving active anticoagulation. Deep vein thrombosis propagation was nearly 3-fold higher in those receiving or managed by ultrasound surveillance. Surprisingly, there was no difference in bleeding outcomes, either major bleeding or clinically relevant non-major bleeding, comparing these two groups, and mortality rates did not differ. So in the end, we did an analysis of net clinical benefit, which combined thrombotic outcomes with bleeding outcomes, and we found that this net clinical benefit favored active anticoagulation 2-to-1 over the surveillance strategy. So in summary, while it's tremendously advantageous to have the guideline recommendations, which allow us for conservative surveillance imaging over anticoagulation for a number of clinical scenarios, you can imagine these clinical scenarios in your practice, our data support a preference for active anticoagulation management for those patients who are otherwise able to take these medications. So for these reasons, I think that this is an important addition to the medical literature and hopefully will be useful for your clinical practice.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.